Well, I think just to make sure that we try and stay on time, we are going to start. Good evening, everybody. My name is Ellen Kodroff. I am the president and founder of the CURED Foundation. And on behalf of Shay and I, we would like to welcome you all here this evening. And we're so glad to offer this conference for free because we believe in making support and information accessible to everyone. We want to especially thank our presenters for this evening, Dr. Collins, Dr. Gupta, Dr. Peterson, Dr. Beveridge, and Dr. Furuta. Thank you all so much for being here and giving your evening to all the patients to help educate us. And also a special thank you to Takeda, our sponsor for the week, for this special webinar series. And also to Julie. Julie is with Cincinnati Children's Hospital. And even though Dr. Collins' name says Julie, Julie Daisy is also on. And we want to thank her for all her hard work. We've been meeting and planning these sessions for probably the last 6 months. And Julie really puts in a lot of time to help CURED. So we want to especially thank Julie. That being said, if you find value in what you're doing tonight, and if you're in a position to give, we'd be incredibly grateful for any donation that you can make, large or small. Every dollar, we believe, brings us a day closer to a cure. And your support helps us continue this work and reach more people. And even if you're not able to donate right now, that's okay. There's another powerful way that you can help. Consider hosting your own Facebook fundraiser or a small home gathering to raise awareness and support. These personal fundraisers really do make a difference, and we can help you get started with templates and tips. Shay will drop a link in the chat right now for donations, and Shay and my email for information on hosting a fundraiser. Thank you again for being part of the CURED community, and Shay is going to share some housekeeping rules for this evening. Let's see. Shay, you're on mute.
Whoops. Good evening, everyone. Sorry about that. I am just going to go over a few things if we could. Please hold your questions till the end of each session. This evening, Dr. Collins' questions are going to be taken right after her session. So if you could put in the chat, or is everybody having problems? We see a few saying that they can't hear. So if you can't hear, can you put that in the chat, please? Dr. Collins' questions are going to be after her session. And if you would please address, before you ask your question, who you would like the question, whether it be the doctor that is talking or maybe a previous. At the end, we will ask. We will ask for additional questions at the end. Okay, thank you for everybody letting us know about the audio.
Yeah. For those who can't hear, maybe if you turn up your sound on your computer, it might be helpful.
Also, when you're asking a question, please do not put your question to a specific case of you or your child. We need that to be a generic question. They are not here to give medical advice. They are not in a position to give medical advice. And all the recordings will be sent to your email. If all goes well, we are able to provide those. And back to you, Ellen.
Okay, thanks. Sorry about that. Our first speaker of the evening is Dr. Margaret Collins. She's the Director of GI Pathology at Cincinnati Children's and a member of the Cincinnati Center for Eosinophilic Disorders. She is also a pathologist for CEGIR, and I've known her personally for a long time, and she is a very giving person to the eosinophilic community. So we are so grateful for you, Dr. Collins, and thank you for being here.
Thank you, Ellen, for permitting me to be here, and to Shay and Julie and all the others who've done so much for this conference in particular. My screen seems to be stuck.
Get louder in my ears, Andrew.
Oops.
And my ears?
Everybody who's not speaking can go on mute, please.
On the what?
Unmute. If you're not the presenter, if you could put your speaker to mute.
Oh. Okay. So I know this isn't the big screen share, but
That's okay. We could see your slide though, fine.
and you can see my arrow.
Yes.
Yeah,
we
see your
can.
cursor?
Great,
Yep.
great. That's more important, actually. So, all right. This is a photograph of the wall of the esophagus, and the biopsies that are obtained endoscopically actually show a very small portion of the wall, not only of the esophagus, but this is true for the rest of the GI tract. In the esophagus, the endoscopically obtained biopsies provide epithelium with usually a small amount of lamina propria attached, if it's attached. But from here, from this white bar all the way to the outside of the esophagus, consists of tissue that is not included in the endoscopic biopsies. One of the reasons this is important is if a patient who's had therapy has persistent symptoms and the endoscopic biopsies are reassuring, their symptoms could be due to events that are occurring deeper in the wall that are not included in the biopsy. So
because one of the male nurses who is retiring, and they're bringing stuff. I forgot.
We're going to ask that everybody please turn your screen to mute.
Eosinophilic esophagitis is the best studied of the EGIDs, and for a diagnosis, at least 15 intraepithelial eosinophils in any high power field at any level in the esophagus is required, along with symptoms that are indicative of esophageal dysfunction. Common goal in clinical work is to reduce the peak eosinophil count to less than 15 per high power field in all high power fields. And for clinical trials, a common endpoint is for a reduction in the peak eosinophil count to 6 or fewer intraepithelial eosinophils in any high power field at any level. I really like this graphical abstract that is now in print at Gastroenterology Hepatology Advances, that shows the pathology of eosinophilic esophagitis. So eosinophils make eosinophil inflammation, and they can occur in the epithelium of EoE as single cells percolating through the epithelium, and or groups and aggregates of eosinophils making small masses that are space-occupying lesions here at the surface, but they can occur deeper, and or rows of eosinophils going along the surface of the epithelium, and or eosinophils that are admixed with surface epithelial cells that are altered, that are staining more pink, more red than the underlying epithelium. In addition,
Dr.
there's,
Collins, can you
Yeah.
speak up a little bit or move closer to your microphone by any chance?
of course, and I can turn that up some. I hope that's better. The basal zone hyperplasia is an expansion of the cells of the lower part of the epithelium. The cells can become, the spaces around the cells can become dilated and reveal parts of the connections between the interfaces between the cells known as desmosomes. Dyskeratotic epithelial cells can form, which are small, darkly staining, darkly pink red staining cells with shrunken nuclei. And the delicate fibrils that normally form the lamina propria can become thick fibers, form lamina propria fibrosis. So here are those abnormalities, should be those abnormalities in real biopsies. The arrows here are pointing to numerous intraepithelial eosinophils. The white asterisk here is showing very substantial eosinophil abscess. The arrows here are showing surface layering of eosinophils, and here the arrowheads are pointing to altered epithelial cells that are more pink than the underlying epithelial cells and are admixed with eosinophils. The bar is, and those comprise the inflammatory subscore of the eosinophilic esophagitis histology scoring system, and these are all the features of that scoring system. In addition, the bar here is showing a very marked basal zone hyperplasia. The asterisks are showing thick fibers in the lamina propria here. This is closer to what normal lamina propria looks like. The arrowheads are pointing to these spaces around the epithelial cells that normally are not seen. And here are dyskeratotic epithelial cells, 1, 2, and 3. And those comprise the architectural or structural subscore of the eosinophilic esophagitis histology scoring system, which scores the severity of the abnormalities using a grade score and the extent or the prevalence of the abnormalities using a stage score on a scale of 0 to 3. The scoring system is responsive, meaning that the scores decrease following administration of therapy that is known to be efficacious for treating eosinophilic esophagitis. And it's also reliable, meaning any pathologist can use it. The individual components have their own significance as well. Basal zone hyperplasia is composed of the lower part of the normal epithelium that becomes hyperplastic. That's really a master regulator of the eosinophilic esophagitis. Also, basal zone hyperplasia is implicated in persistent symptoms of patients whose biopsies look much better and have a peak count less than 15 or 0, but who also have persistent symptoms. So that's a target for therapy in patients in that situation. Dilated intercellular spaces correlate with reduced impedance, meaning that it's easier for ion flux to occur across epithelial cells. And so not surprising that antigens such as gliadin, which is a component of gluten, can become part of the epithelium. They can be stained in the epithelium. Of course, they don't belong. These two features, surface epithelial alteration and dyskeratotic epithelial cells, when they occur together in the same biopsy, predict the presence of lamina propria fibrosis. And here is a website where you can put in the scores and get the risk of having lamina propria fibrosis, which is important because in most biopsies, lamina propria is either not there or it's so crushed that it can't be adequately evaluated. And these 4 components of the HSS plus an endoscopic feature known as furrows, which are vertical lines in the esophageal mucosa that are seen endoscopically in patients who have eosinophilic esophagitis. All of those scores put together have a very high sensitivity, specificity, and accuracy for predicting active eosinophilic esophagitis. And finally, artificial intelligence is being used in a number of ways to study eosinophilic esophagitis, including biopsies of eosinophilic esophagitis. So in this particular study, without getting into too much detail because I don't understand a whole bit, there are good correlations that are significant between the scores that were given by pathologists for basal zone hyperplasia grade and stage and the scores that were assigned by a machine that learned how to do it, as well as for peak eosinophil counts. Those correlations were very good and highly statistically significant. Hopefully these algorithms, these programs will become commercially available soon so that counting eosinophils and scoring the biopsies using the scoring system will become easier. So for the rest of the GI tract, knowing which threshold value is the best threshold value is not universally agreed upon. This is a more difficult task than it was with the esophagus. In the esophagus, that normally there aren't any eosinophils. In the rest of the GI tract, there are. And finding that demarcation between what is normal and what is for sure eosinophilic gastritis is not particularly easy. These are values that were published in January of 2024 in the journal JPGN for children. Values per high-powered field. Work in this area continues. In the meantime, there are abnormalities other than excess numbers of eosinophils in the rest of the GI tract, just like there are in the esophagus. Some of these occur in the stomach and the intestines, such as lamina propria eosinophil sheets, too many intraepithelial eosinophils, collars of eosinophils surrounding glands and crypts, eosinophils in the muscularis mucosa and the submucosa. We'll see all of these. But then there are abnormalities that are also specific to the particular site, like in the stomach, intestinal metaplasia. Goblet cells are normally found in the small intestine and colon, not in the stomach, but in EOG they can be as part of a metaplastic process where some types of epithelium become different types of. In the small bowel, including the duodenum, villus atrophy can occur. That's the only part of the GI tract that normally contains it. And this could be incorrect. It's my impression, but I believe that based on my experience that eosinophilic cryptitis has a higher rate of crypt loss and crypt dropout than do the other EGIDs, EOG or EOD. But see as we gain more experience if that really is true. Eosinophilic gastritis, lots and lots of eosinophils here at the surface of this biopsy. Gradient is normally the reverse. More eosinophils are found deep in the normal mucosa of the stomach than are found at the surface, but here we've got a lot. There's some of the sheets here, and in some places it looks like they're actually pushing the glands away from each other. A lot of reactive epithelial cells, big nuclei, they shouldn't be that big. And in this particular instance, an open biopsy and a biopsy of the muscularis propria, the big muscle on the outside of the GI tract, all parts of the GI tract, was loaded with the eosinophils. Normally, the muscularis propria doesn't contain any eosinophils. There are lots of eosinophils in biopsy. Another example of eosinophilic gastritis, again, a lot of eosinophils. One might even think when you first look at this that this could have been duodenum because this is reminiscent of a villus, but this actually did come from the stomach, and this is so-called pseudovillus transformation of the stomach. A lot of eosinophils here. Some of the glands are cut in correct orientation. longitudinally. Eosinophils in the epithelium, too many eosinophils in some of these. One eosinophil per gland or crypt is acceptable, but these have many more than that. And these glands over here are not running particularly perpendicular. It looks more like they're starting to run parallel to the surface, which probably indicates a significant amount of chronicity. Again, there are the eosinophils that are hugging the outside of the glands. We know from the work of our beloved colleague, Hirano, that the features that he designed in the eosinophilic gastritis refs system, scoring system for the endoscopic findings in eosinophilic gastritis, those features correlate moderately with the eosinophil counts and significantly with the eosinophil counts in eosinophilic gastritis. We also know now that the features that we've been scoring correlate strongly with T2 cells, Th2 cells in gastric biopsies, including the cells that exhibit IL-4, IL-5, and IL-13. The features that we thought would not correlate with those other metrics don't. So the differential diagnosis of eosinophilic gastritis includes H. pylori gastritis. There can be a lot of eosinophils in the lamina propria of biopsies that have H. pylori. The only way to be sure that that's H. pylori and not eosinophilic gastritis, or a good way to be sure, is to do an immunohistochemical stain on the biopsy. Sometimes there are so many organisms you can see them without the stain. Collagenous gastritis is a disorder that clinically closely mimics eosinophilic gastritis. And increasingly in children and adults, we're recognizing biopsies that have both thick collagen tables underneath the surface. That's what collagenous gastritis is. And a lot of eosinophils that would qualify as eosinophilic gastritis. Whether this is a new disease, or this is a form of collagenous gastritis or a form of eosinophilic gastritis, we haven't worked out yet. And another area where we need to do more work and gain better understanding is distinguishing between eosinophilic gastritis and a form of autoimmune gastritis, a form that's called atrophic metaplastic autoimmune gastritis, that in part of its life cycle exhibits a lot of eosinophils in the lamina propria as well. Sometimes in eosinophilic gastritis, there are a lot of plasma cells, especially following therapy. And plasma cells are cells that secrete a lot of antibodies. They always make you think when they're there in big numbers, whether there is an autoimmune disorder. So this is another area where we need to focus and begin to understand demarcation is between the two diseases. So eosinophilic duodenitis, illustrated here. This epithelium looks like gastric epithelium, and but this really did come from the duodenum. This can happen in patients who have peptic duodenitis too. When there's too much acid getting from the stomach into the duodenum, this kind of change can occur in the epithelium there. But otherwise, there may be that's a villus over there, but not anywhere else here. And there are a lot of eosinophils in the area. Here are some goblet cells, but this crypt doesn't have any goblet cells. And again, there are some eosinophils right around the rim of the crypts here. This is a particularly disturbing example of eosinophilic duodenitis. Excuse me, there are hardly any villi. The crypts are extremely long. The arrows are pointing to eosinophils, a lot of eosinophils in the lamina propria. And here are eosinophils in the muscularis mucosa, where they normally don't occur, and also in the submucosa, where they normally don't. And that's always been taught classically as a sign of an aggressive eosinophil disorder. This is a graph from a small single institution study that shows that the transcriptome that's characteristic of eosinophilic duodenitis begins to really manifest itself when there are more than 50 eosinophils in a high-power field. So maybe that's a good starting place, a good threshold number for a diagnosis of eosinophilic duodenitis. And the differential diagnosis for eosinophilic duodenitis is extensive hypereosinophilic syndrome, vasculitis, connective tissue disorders, infection, interestingly, not H. pylori. Typically, H. pylori can infect the stomach and the duodenum. And when it infects the duodenum, it usually does not evoke an eosinophil response. Also, Giardia, which is a parasite, is not normally associated with an eosinophil infiltrate, with villus atrophy, but not with eosinophil infiltrate. Inflammatory bowel disease can be associated with pronounced eosinophil infiltrate in the upper tract and so on. So moving on finally to eosinophilic colitis, here we see a lot of eosinophils at the edge of this crypt, also invading that crypt. Some eosinophils up here might have destroyed the upper part of this crypt. There are eosinophils down here underneath the crypts that are elevated above the muscularis mucosa. They're supposed to be resting on the muscularis mucosa. They aren't. That too is usually taken as a sign of chronicity. Here, even though this is a poorly oriented biopsy, there are an awful lot of eosinophils here right around the crypts in some areas and inside the crypt epithelium in other areas. And some crypts don't have any goblet cells whatsoever. They're supposed to have a lot of them. Some crypts have a few remaining, others none. And loss of mucin is a sign of a response on the part of the GI epithelium to probably a significant stimulus. Surprisingly, here, these are enlargements of this. A stain that marks cells that are not in G0, so not in the resting phase, and could be proliferating, shows in normal colon biopsies, a good percentage of the cells are out of G0. And that's right, the epithelium turns over every couple of days. In Crohn's disease that is inflamed with eosinophils, there's a good number of such cells, but not in eosinophilic colitis. Many fewer cells are staining out of the G0 cell cycle. G0 of the cell cycle. In contrast, cleaved caspase 3 is a marker of apoptosis, which is programmed cell death. There's hardly any staining in a biopsy. There's more in a biopsy from inflammatory bowel disease that has an excess number of eosinophils in the lamina propria, but there's the most in eosinophilic colitis, not only in the lamina propria, but in the surface of the epithelium as well, which is not what was being expected. In this graph, we see that some of the features that we've been evaluating in eosinophilic colitis correlate both strongly positively and strongly negatively with some of the genes that comprising the eosinophilic colitis transcriptomes. So in summary, EGID are characterized by excessive numbers of mucosal eosinophils and additional pathologic abnormalities. They can be important for a number of reasons, but one of them is to help us determine what's chronic disease and what's not chronic disease. EGID transcriptomes correlate with pathologic abnormalities. EOE, EOG, and EOD transcriptomes are consistent with the type 2 disease, but the EOC transcriptome is less identifiable as a type 2 disease. And in general, we need to work a lot more on EOC to figure out what's going on there. So thanks to the CCHNC EGID pathology team that cuts slides and processes slides and does slide scanning and digital pathology and data entry and all sorts of good things that keep the EGID work going. So thank you for your attention, and I'm happy to take questions.
Hi, does anybody have any questions that they want to put in the chat for Dr. Collins? If not, thank you so much.
Of course.
And we
Thank
are
you.
so grateful to have you here. Thank you again.
Thank you.
There just one came in. Just as we were typing.
Jay?
There is a question. Can duodenal lymphocytosis also indicate EOD?
Duodenal lymphocytosis, can that indicate EOD? Not to my knowledge. Not to my knowledge. That is one of the features that we've been keeping track of in our evaluation of duodenal biopsies for whether they do or don't have EOD. And I don't know all the data. I can just speak for biopsies that I have evaluated, and I can't say I've seen an association with lymphocytosis. And if it did occur, sometimes drugs can cause intraepithelial lymphocytosis. So actually my first thought would be, what drugs is the patient taking, and are any of them known to cause intraepithelial lymphocytosis? That's an interesting question. Thank you.
There is a few more questions. The next one is, why do you think pathology lab would not quantify eosinophils?
It's time consuming, and some pathologists are kind of insulted that they would be asked to do that, because they believe that's something that should be done by a histotechnologist or someone other than them. So those are the reasons of which I am aware that they will not, or they refuse to count eosinophils. That's the main reason why we're working hard, more and more harder, to try to get AI papers published and try to come up with the best algorithms that we can, and to get them on the market, because at an inexpensive price, because then there really isn't a reason to not have an eosinophil quantitation, which would actually be better than what we're doing now. We give a peak eosinophil count. These things count all the eosinophils that are in biopsy and come up with not only a peak count, a mean and a median count, and all sorts of other statistics that actually are helpful to some GI docs. They really want some kind of mean or median. They want more than a peak count. So, I'm hoping in the next few years that it won't matter whether a lab does or doesn't have people who will count. All they need to do is scan their slide, and everybody's scanning these days. And some of these programs work very quickly. And of course, it depends on how many eosinophils there are in a biopsy. That could slow the program down, but generally they're very quick.
Dr. Collins, the next question is, what is a T2 disease?
Oh, a type 2 disease, I'm sorry, that's an atopic or allergic disease. Asthma is a type 2 disease. Atopic dermatitis is a type 2 disease. Chronic rhinosinusitis with polyps is a type 2 disease. And EGIDs in general, not EOC, it seems, but the rest of them have the genetic and milieu of type 2 diseases.
The next question is there a chance that eosinophils will be cleared and will not come back? What is the best way to avoid flare-ups aside from food elimination?
I think that the clinicians will be better able to, more accurately able to respond to this question. So let's keep this question in mind as we move through the evening. But
Yes, I realized after I asked it. There is another one. Shay, do you want to get that one from Sarah?
Are we closer to articulating endotypes, which could then aid selecting treatment options?
great question. We've got them in EOE. I would say you know that already. Are we closer? Yeah, we're closer. I don't know that they've been declared yet in EOG or EOD. EOC is another matter. But EOG, I would think would be the next of the EGIDs that yeah, we could have endotypes identified, and that actually could come fairly soon.
And I think we covered all of them. Let me just scroll here real quick. I don't want to miss anybody. I think that's all the questions we have posted for now. Thank you, Dr. Collins.
Of course, thank you all.
Okay, thank you all. We're gonna move on to Dr. Claire Beveridge. She is with us tonight. She is assistant professor in GI and the director of eosinophilic esophagitis at Cleveland Clinic. She is also a current CEGIR Hirano scholar. So I'd like to welcome Dr. Claire Beveridge.
Thank you so much for inviting me and for having me here. Make sure my screen is working just fine. There we go. And let me share my slides. Okay, can you see my slides?
Yeah. Yes, we can.
Ooh, it got me to the end. I'm done with my talk, everyone. I'm kidding. Start from the beginning. Thank you again so much for inviting me to talk today. My name is Claire Beveridge. As you heard, I'm one of the CEGIR Hirano scholars. Very honored to be one of them. I work at Cleveland Clinic and I run the EOE Center there. And I was asked to, introduce myself, talk about who I am, where I work, what I do. We'll talk a little bit about my EOE clinic and then the research that I do. So for background, I grew up in Bethesda, Maryland, which is right outside of the DC area, to a physician father and a teacher mother. My mom ended up being a therapeutic horseback riding instructor. And then I have two older sisters. In terms of the training that I did, I kind of ping-ponged between Philadelphia and Chicago for a while. And I finished with my training in Philly, where I did my gastroenterology fellowship there. And that's really where my passion for esophageal diseases and specifically EOE really came about. And I did my advanced esophagology fellowship there under the mentorship of Dr. Gary Falk and Dr. Chrissy Lynch. And here is my image of a very happy esophagus. We always like to keep it happy. Currently, I live in Cleveland, Ohio, with my son. With my two sons, my husband, and a dog. My oldest son is a little over 3, and my youngest is a little over 6 months now. But I was recruited from Philadelphia, 4 years ago now to start the EOE clinic at Cleveland Clinic, which I was very honored to do and happy to do. And I split my time in terms of doing my clinical work as well as my research there. So in terms of the EOE clinic that we have, we really try to make sure that it's as patient-centered and patient-focused as possible, where, you see me in the GI clinic, but I make sure that, and, my colleagues who I work with in the EOE center, but we make sure to, work very closely with the other physicians and providers who our EOE patients are seeing, because as you all know, it's more than seeing GI. It's also seeing allergy, it's seeing pulmonary, working, very closely with your pathologist. We also work very closely with our GI psychologist, just because you could develop a lot of fear of swallowing, even when we get the histology controlled and the scar tissue controlled. We also work very carefully with our registered dietitians. There's, one in particular who I work very carefully with, and we meet routinely to discuss the latest literature on elimination diets so that we can really help guide patients through the process in terms of doing those diets. And then one that I really want to highlight is our transition clinic. So I lead this with Dr. Sophia Patel, who is my pediatric gastroenterologist counterpart at Cleveland Clinic. And, a lot of our patients can be diagnosed at very young ages in the pediatric side, and then they have to transition at some point to us in the adult hospital, and we like to make it as smooth a transition as possible. So, we've worked very carefully and closely to do this transition jointly so that nothing falls through the cracks, and the patients are really well taken care of through that whole process. In terms of some of the research that I've done, I'm just going to focus on the EOE research that I've done. But some of the most recent ones that I have published would be, why do patients with EOE have persistent esophageal symptoms, whether it's difficulty with swallowing, heartburn, chest pain, despite us seeing that they're in histologic remission, meaning when we take those biopsies, it's less than 15 eosinophils per high power field. And what we found in our retrospective study, so looking at a whole bunch of different charts from the last few years, some things that can be very important will be fibrostenosis, so scar tissue in the esophagus that will lead to persistent difficulty with swallowing, especially for heartburn and chest pain. Sometimes what can contribute to that is, maybe we need to target actually a lower eosinophil count than 15. And then something else that's been described before, but kind of esophageal hypervigilance. So if you've been suffering from difficulty with swallowing for a while, then you can be very hypervigilant in terms of how your swallowing feels, but there can also be, sensitive nerves there. So, a lot of interplay with that. And then specifically for looking at, that those stenoses, the narrowing that can happen in the esophagus, what diameter should we target to help patients feel better? What diameter ends up being clinically significant? Should we dilate any stricture that we see, any narrowing that we see, or only if it's a certain diameter threshold? And so, we found that targeting 16 millimeters or greater leads to resolution of difficulty with swallowing. Now, both of these were retrospective studies, so kind of our next step is to do more of a prospective approach, where we follow patients from the start and ask a lot of patient-reported outcome questions, do more studies in terms of using a functional luminal imaging probe, which helps give a more precise measurement of what the diameters can be in the esophagus. So we're actively working on that and hope to have the data for that in the next year. And as you can tell, a lot of what I'm interested in is also, seeing that fibrostenosis, that scar tissue that can happen in EOE. And so a major thing that I did was to do a systematic review of all of the literature that we have on fibrous stenosis, for which there is a lot, to kind of assess, what terminology is used, how do we define it, and we see that there's a lot of variability in how we're doing it in clinic and in research. And so this is kind of the first step to try to simplify it a little bit more, so that we're kind of using common terminology amongst everyone. And then I had done a review on EOE therapies, which is probably a little outdated at this point, because that was done in 2020. A lot of the, PPI, topical corticosteroids, is, still fine, but it didn't quite capture dupilumab and some of the more recent ones. So what are my future goals? A huge future goal is to, contribute to the space in EOE and really to push, help push the field forward along with all of these other, amazing clinicians, researchers who are here today who have kind of, started this path. And so in order to accomplish that, been very fortunate to get the support of the CEGIR Hirano scholarship, as well as getting an ACG award. The ACG is one of our, national GI societies. And, the two things that are really important to me, I've kind of addressed one of them already, which is fibrous stenosis, looking at that scar tissue, and, working for a translational approach of, taking these biopsies and working with a few of the labs that we have at Cleveland Clinic to assess that further. And then another goal that I have is to, contribute to the field in terms of, minimally invasive and non-invasive methods that we can maybe use to assess for EOE, because it can be very frustrating for patients to always need endoscopies. Now, I don't think that this is going to get rid of endoscopies, right? But it would be nice to have another method that may, be able to minimize the number of endoscopies that we're asking patients to do, right? It requires sedation, it requires taking a whole day off of work, not being able to eat and drink for a while, sedation, it's a minimal risk, but there's still risks associated with the procedure. So the method that we're looking at is to look at breath samples for patients with EOE. So if you blow into this Mylar bag right here and we collect the breath of patients, can we analyze the different gaseous compounds that are within the breath to find a distinct pattern for EOE? And this has been looked at in terms of other disease states, so asthma, inflammatory bowel disease, acid reflux, certain cancers. It hasn't really been assessed yet for EOE, so that's been one of my main projects to look at. We published a pilot data on it, and now we're kind of working on a much larger scale for it. But we're hoping, this isn't a short-term thing. It's going to take some time, but we're hoping to find a non-invasive method to contribute to the other methods that we have available. So I want to thank my research team, who I work very closely with, and the funding and the support that I get through the CEGIR Scholar Training Award, through Cleveland Clinic, and through ACG. And then I can stop here and see if there are any questions for me.
Hi, so we are going to save all the questions for the end, after everyone has a chance to speak. I just wanted to clarify that you treat adult patients. Is that correct?
I do, yes.
And that in our world is very special because there seems to be so many more pediatrics. So I just wanted the community and everybody on the call know, because I know we have a lot of adult patients on the call. So
yes.
Thank you very much.
Adult gastroenterologists for adult patients. Exactly.
Yeah. So if someone wants to put questions in the chat now, just put Dr. Beveridge's name by it, and we will ask him at the end. That way you won't forget. And at this point, I'm going to introduce our next speaker is Dr. Sandeep Gupta. He's the director of the Division of Gastroenterology at Children's of Alabama and a principal investigator for CEGIR. And his title is Where Are We with Steroid Therapies for EGIDs as well as Eohilia? Thank you for being here, Dr. Gupta. You are on mute. I am reaching out to let him know, so hopefully he'll be ready to start. Okay, he's coming. He'll be here in 1 minute. So, Shay, we can go ahead and ask the question really quick. I see there was a question in there for Dr. Beveridge. You mentioned issues with the scar tissue. Is that from the disease itself? Do multiple endoscopies also tend to lead to scar tissue?
That is a great question. I was just typing up my answers, so now I get to say it, which is perfect. So the way that I think about it and describe it is when you have uncontrolled inflammation, that will lead to scar tissue happening. So whether that's related, to having erosive acid reflux, eosinophilic esophagitis, that inflammation is what's going to lead to scar tissue. And so in terms of treating EoE, we need to make sure that we get the underlying inflammation under control so that more scar tissue, more fibrosis doesn't develop. And then you asked specifically if, so yes, it's from the disease itself, the inflammation from the disease, and multiple endoscopies aren't going to lead to scar tissue. The endoscopies itself often are helping to treat the scar tissue if it's there, to stretch it open, to do a dilation, but just doing it itself and taking biopsies won't lead to scar tissue. And then I see another question.
We're going to go on to Dr. Gupta, and then we're going to come back to your next question. Thank you so much. Dr. Gupta, are you going to share some slides?
Yes. Hello, everyone. Can you hear me good and loud and clear? Fantastic. Thank you for this opportunity. Really love it. Thank you. Thank you for organizing this, Ellen, and your team. I'm super honored to present on steroid therapies in EoE. I'll make sure I time myself. It's about 20 minutes I have. There'll be quite a bit of information we'll be covering, but I think I want to give you the highlights, especially since I want to give you things that you bring to your next visits to the hospital or the clinic and are as informed as possible. So I'm at UAB, University of Alabama in Birmingham. I'm at the Children's of Alabama. I've been doing EoE. My first presentation on this was I can't believe this, I'm saying this, May 1995, DDW 1995. So here we are 30 years later. These are my, if I can, objectives to summarize some of the endpoints in EoE. And I'm sorry if you have already heard some of the information, but also good to get some refresher done. Describe some of the data on topical corticosteroids that may be abbreviated as TCS in some of the slides, and then recognize some of the nuances of steroid therapy. At the bottom of this slide are my disclosures. So first of all, I think it's really important, and I'm sure many of you're already familiar that EOE is more than just number of eosinophils. And as you live with yourself or your family members who have this condition, there are more things that you go through, including symptoms. So when you look at the endpoints of this condition, there are in this top square here are the total number of studies, studies that have histological endpoints, that have endoscopic endpoints, and symptom-based endpoints. And as you will see, over the years, the number of studies has gone up, as you can see on the y-axis, uh, but also that not all studies have all the three parameters, which is total number of studies in the black column, but some that have only histological endpoints, some only endoscopic, and some only system-based. So really what we are aiming is for the holy grail of this black line, where the studies have all of these endpoints reported, because there is more than just number of eosinophils to EOE. The other thing you want to know is that we know more than 15 eosinophils per high power field suggest active disease. When you look at the literature, there are two numbers. Sometimes you hear the word response and sometimes you see the word remission. Remission is when you have dropped to 5 or fewer eosinophils. Response is you have between 6 to 14. I think more and more the world is moving towards over 15 or under 15. It is in the clinical trials that you will see the more rigor of remission. In clinical practice, regular practice, you will see 14 or fewer, and people are generally going to be okay, we have it under control. And this again looks at the box and whisker plot. It looks like box and whiskers on histological, endoscopic, and system-based placebo response and remission in EOE. So when you look at placebo, like in this histological response, drug seems to respond better than placebo. Same for endoscopic, but symptoms are generally similar. So what we call is a placebo effect in this condition with studies that a patient may be getting a placebo, a sugar pill, but they feel better though their endoscopy and their histology doesn't improve. And that is one of the challenges with getting FDA approval for these, for drugs for EOE, is that we also need symptom response. So really, when you're at the visit with your doctor next time, you really want to have a conversation. What is a number? Is it a response or a remission? Most of the time, many of us are going in a response category of less than 15 is okay. You also want to know how was the endoscopy, and you want to tell your physician how the symptoms are. This is another nice study or a commentary from Dr. Hill in Philadelphia, who talked about the core outcomes: pathology, histology that we talked about, endoscopy, symptoms, and also quality of life. At the end of the day, it ends up being, how do I feel? How is my life? Is the disease leading my life, or am I able to live my life with the disease around me? So really, these are the things we really, all of us, both providers and patients and families, have to start focusing on, just not the number of eosinophils, but the entire patient and the entire picture. So those are some of the things I wanted to just level set on clinical care. Now, what are the treatment options? This is a study. This is a clinical guideline from ACG, which is the American College of Gastroenterology, on initial therapy for EOE. And if you look at the purple or the blue boxes, if you have somebody who has EOE, you can consider pharmacological therapy, or on the other side, the diet. And under medications, you have PPI or topical corticosteroids or TCS. So, and we'll be talking about the purple TCS box today in my talk. Which of these purple boxes do you pick? A lot depends on their efficacy and safety. Is the patient on multiple medications? Does the patient have other what we call comorbidities like eczema, asthma, or weak bones that you want to be careful with some therapy than other? How bad is the disease? Is there a fibrosis? Is there a stricture? What is the patient's preference? How is their lifestyle? Can they really mix the budesonide into a slurry? And of course, you have to be aware of insurance coverage. It doesn't always dictate what we do, but often it is a variable we have to be actively concerned about. And if you go for diet, then do you have a dietitian available? Is there do you have a multidisciplinary clinic where a dietitian can educate the patient? So all of this at the end of the day is that there has to be shared decision making between the patient, the family, and the provider on what to do for their EOE. EOE is like blood pressure and diabetes and cholesterol is a long-term condition. It's not like a ear infection or a sore throat that will go away in a week. So really, if you're going to treat something long-term, you really have to do shared decision making and get everybody's input and then make and come to a consensus where everybody is comfortable. You may not get everything you want, but that hardly happens in life where one party gets everything. It's always a compromise, but aim for that. And if your provider is not willing to do that, then it should be a red flag for you, because people may not be aware of this condition and they may think this their way is the right way, and that is not the case. So please engage your provider, and if needed, find other people who will listen to you and will engage you in the decision making. What are the different outcomes? Generally, I would say with diet and topical corticosteroids, so the second row and the fourth row are similar. About the typical diet, the 4-food or 6-food diet is about 65, about 2/3 of the patient respond, which is, again, you want to look at the pink, which is less than 15 eosinophils, not less than 5, but less than 15. About 2/3 of the patient on diet respond, and about 2/3 of patients on topical corticosteroid respond. With PPI is about 30 to 40% that respond. So some difference in response, but again, not like 90% versus 10%, in that whole ballpark of a little bit below 50 or a little bit above 50%. Now, talking a little bit more about topical corticosteroids, there are multiple studies that have been done, as you see on the left side of the slide. And look at the bottom purple square or rectangle, where when you take the average of all of these studies and you look at this diamond, the black diamond, it favors corticosteroids over placebo. So when you look at the entire effectiveness of these studies, it favors topical corticosteroids. The reference at the bottom is from a Cochrane study review we did for Cochrane, and I'll show you the reference at the end. And this slide and a couple other are due courtesy of my colleague, Dr. Natalie Nugent from Denver, Colorado Children's. This slide is also from her, and I adapted a little bit, is looking at the journey of corticosteroids. So really, actually, the first indication of corticosteroids came in 1998. In the same year, 2 papers got published, one with the use of prednisone from CHOP and the other on using topical corticosteroid, the inhaler. Both papers came in 1998. That's all we had in those days. Then we did a study that came out that started in the 2000s and was published in 2008, comparing prednisone and fluticasone, because those are the only 2 drugs we had. Then around 2010, there was a first study with the use of oral viscous budesonide using in Splenda. Then a bit later, a study came out on maintenance of budesonide and using it long-term budesonide treatment. And then it was followed by a comparative study on viscous topical budesonide versus the inhaler, followed by the EMA, is the FDA of Europe. It's called Europe Medical Agency, that approved the budesonide tablet that dissolves in the mouth, known as Jorveza. And then we were lucky in the US, in a couple of years ago, we got the approval for Eohilia, which is the budesonide oral suspension. So you can see it took from like 1998, the top box here, to about 2023, 2020, 2004 in the US that we got the first approved drug that is topical corticosteroid based. In the next few slides, I'll just show you representatives data from each of these options. This is on oral viscous budesonide, 2 milligrams twice a day for EoE. And when you compare placebo, which is black, versus budesonide, which is blue, the histological response, which is less than 6 eosinophils, was much better in the drug versus placebo. However, the symptoms were significantly different, but not as markedly different as they were for histology. But again, the blue is drug, placebo is gray, and there was a significant difference in symptoms also. This is study from Europe on Jorveza, the tablet that dissolves in the mouth, known as BOT, budesonide orodispersible tablet. And in this study, you can see that the clinical response with drug, which is in green, was much better than placebo, which is in gray. Histologically, hardly anybody in placebo responded, whereas 93% with drug responded. And there was a significant difference in symptoms also, and when you combine the two things also. This study led to the approval of the drug by EMA. This is a study ongoing in the US on fluticasone-based oral tablets. So the Jorveza is budesonide-based. This is fluticasone-based, and the study is by a company called Aptalis. And they looked at 4 different doses of drug, APT, 3 milligrams twice a day, 3 milligrams once at bedtime, 1.5 twice a day, 1.5 once a day, and placebo. Placebo is this black line, and there was no hard, it performed not as well as the drugs, which are in the different colors here. And you can see the same on the left side of the slide, where placebo hardly had any response, and both had 12 weeks, 26 weeks, and 52 weeks. So drug performed really well. We are yet to get the final results on this drug and where the company is now. The company is now called Adair. It was Aptalis, now it's called Adair. This study is the one I talked to you about, was the comparing prednisone with fluticasone. Now, we hardly ever use prednisone now, but that was then when we didn't have much options. And in all parameters, generally, prednisone and fluticasone was similar in terms of symptom resolution and histological score. But when you look at resolution of histology, prednisone did better than fluticasone in getting the eosinophils less than 5 per high power field. The next 2 slides will be some summary statements. This is from ASPIGAN, which is the European Society for Pediatric Gastroenterology, Hepatology, and Nutrition. This position statement came out recently, and I took some pieces from that and some recommendations. So first of all, they recommend that topical corticosteroids can be one of the first-line treatments to induce remission in EoE. There is no clear evidence showing the superiority of one topical corticosteroid over the other, so they all appear to be similar. So that should give you some relief that you are not, if your doctor gives you fluticasone and not budesonide or the other way around, that you are not getting the short end of the stick. It appears that drugs are similar, and that use of topical corticosteroids for treatment of EoE in children is considered safe. So I think these recommendations, if I was a patient or a parent, would give me some reassurance and peace that if my doctor gives me topical corticosteroids, they're not giving me like a 5th line treatment as first line, but these are first line treatment. No matter what drug you use, there seems to be similarity, and they are generally safe. Now, nothing in life is 100% safe, but these are generally considered safe, though there is some risk of adrenal insufficiency, and we'll talk about that in a little bit. This is that American College of Gastroenterology guidelines that I showed you earlier. And here also they mentioned that topical corticosteroids improve symptoms, histology, and endoscopic features in adolescents and adults. They advise that these drugs are taken after meals or before bedtime. And the reason we say after meals is that so that you have done eating and your belly is full, and now you can take the drugs so it can stick in the esophagus and not wash off with the next bite of food. At least you need about 30 to 60 minutes to let it stick to your esophagus, like putting cream to the skin. And that in young children, consider using a slurry or suspension rather than the inhaler device. What are the different corticosteroid formulations out there? There is budesonide that many of us are familiar using, which is a liquid respule pulmicort that you mix in some different types of carrier things like honey or applesauce. Now, don't use honey under the age of 1. Applesauce, Splenda, whatever your provider and you land on. Then there is a Jorveza, which is the pill in Europe. Then there's Eohilia, which is an oral suspension, a packet that you shake, and that is FDA approved in the US. We have the fluticasone inhaler that many of us are familiar with. And then is the fluticasone tablet that I showed you from Adair, the multiple color graph, which is still under study and not FDA approved yet. The other thing I wanted to share with you is that we don't like to keep, at least I don't like to keep what I call the induction dose forever and ever. After I start something and I have shown in 3 to 4 months by endoscopy that the inflammation is better and where I want to be in remission, then I decrease the dose. And in this study at month 3, they decreased the dose by 50% thereafter, and 3/4, which is 73%, stayed in remission after 50% dose reduction, but in some, the disease came back. So I would say personally, my preference is to decrease the dose gradually over after inducing remission and then doing a scope after some months to see how the patient is doing. Sometimes they stay well, sometimes the disease acts up again and I have to go back up on the dose. But there's no way to know till I do it. This was an interesting study presented came earlier this year in American Journal of Gastroenterology, and this talked about patients who had failed what is called OLSTC, off-label swallow topical corticosteroid, and then they gave them a steroid formulation that was esophagus targeted Eohilia, and they found that 42% of those that did not respond to the off-label drug now responded to the targeted formulation. And so that was, and those that even had responded to the off-label, and when they switched them to the targeted one, they still responded. But I think the main message is that if you do not respond to the off-label one, it is worth trying the labeled one, the FDA approved one, to see if you respond to that. Last few slides, topical side effects of topical corticosteroids. One is Candida infection. So that's why we say in the food pipe, you can get Candida, yeast overgrowth. So we recommend that you take it after meals, nothing to eat or drink for 30 minutes, and then drink some liquid to wash off the medicine. Otherwise, if it sticks in the esophagus forever, you can get yeast infection. The other is adrenal insufficiency. So in our bodies, we all make steroid internally. And if you give external steroids over time, there is concern that your body's production of steroids will go down, which is known as adrenal insufficiency. Different providers practice differently. Your doctor may wish to test for it after you have been on the stable dose for 6-8 months. They may want to test and make sure that your internal production of steroid is not compromised. That is known as adrenal insufficiency. Have a conversation with your provider. I don't think there is any standardized way most of us are doing in the country. Different people do differently, but at least have a conversation with your provider. Summary and take-home points. There are multifactorial endpoints to consider beyond just the eosinophil high power count, eosinophils per high power field, and also there's a placebo effect of this condition. Sheer decision making is core, and if there's one thing you take from this talk is that make sure your provider is engaging you. If not, please ask them to engage you. And if you don't get anywhere, it may be a sign that you need to find someone else. There are multiple guidelines from different societies that I showed you that place topical corticosteroids as first-line therapy, among other options. Pay attention to the formulation, dose, frequency, administration. Often when I see a patient has not responded to it because they have not done it right. For example, generally with applesauce, I tell them to mix it in a tablespoon of applesauce. And sometimes families will take a whole serving of applesauce, that 4 to 6 or 8 ounce canister of applesauce, and mix the medicine in it. Then there's so little medicine and so much applesauce that they don't get it. And if you're on the right age, you may even take Eohilia, the FDA-approved formulation. Best of luck to you and your family. And this is the Cochrane review I talked about that we published a couple of years ago on medical treatment of eosinophilic esophagitis. I'm grateful to many colleagues for educating me, working with me, and I'm happy to take any questions.
Dr. Gupta, we're going to do the questions after Dr. Peterson and Dr. Furuta speak. So will you be able to stick around?
I will try.
Okay, thank you.
Thank you.
Shay?
Thank you, Dr. Gupta. I am happy to introduce Dr. Catherine Peterson. She's a professor of gastroenterology at University of Utah, health and principal investigator for CEGIR. And she's going to talk to us tonight about lower EGIDs.
Thanks, Shay. Let me see if I can share my slides. And thanks everybody for coming today. Let me see. Here we go. We share.
Yep.
And then let me get it going. Sorry. All right, and then do my slideshow. Thanks everybody for coming tonight. I have a bajillion slides, so I'm going to try to limit this because I know I have like 20 minutes to talk, and it is a very big topic. So I will try to do it justice. I know Dr. Gonzalez was going to give this talk today, and you're stuck with me, but I will try to do everything justice. So I am going to talk today about lower eosinophilic gastrointestinal diseases, and then show off all of my artificial intelligence diagrams that I've been able to make. So my objectives today are to talk about the categories and associated symptoms of lower EGIDs and discuss some of the risk factors and associations that we see, although not much is known, and I'll explain why. And then understanding issues with some of the therapeutics for disease, and then learning about a couple of like potential new ways of looking at the disease or developing biomarkers, so that we aren't maybe as dependent as somebody had talked about earlier on pathologists enumerating eosinophils, because that is difficult at times. So I've got a big group of information I'm going to try to portray and hopefully not talk too fast.
Dr. Peterson, your slides have gone away. Your slides are
they
no
went
longer
away?
there. Yeah.
That is so weird. May stop share. It says I'm screen sharing. Let's see. Let me try. That is weird. Okay, hold on. Let me see. Or I'll just sit there and talk off the top of my head, huh? Okay. Did this work for you guys?
Yep, there they are.
Okay, we're going to try this. Hopefully this will work. Okay, so what is a lower eosinophilic gastrointestinal disease? It really, the way we think about that is that it's anything that affects your GI tract that's not your esophagus. So your stomach, you know, the multiple feet of small bowel that you have, the first part of your small bowel, the middle part, the last part of your small bowel, or your colon, or a combination of anything like that with eosinophilic esophagitis. So it can be a pattern, and we'll talk about that. And so that's what gets to be a little difficult talking about lower EGIDs, because it is this huge kind of area, even though it's considered rare. What we are seeing, though, based on this one study that was published out of Sweden and out of some others, is that we are seeing increased incidence or increased diagnoses of these diseases. And probably it's at least in part, hopefully, that we're recognizing them more. It's unclear, probably also the fact that we are seeing more allergic type diseases kind of coming out. Allergy is kind of considered to be kind of this blossoming new disease state that we're seeing in people in general. And there's multiple thoughts behind that I'm sure Dr. Jensen will talk about a little bit later. And this is just a slide that's extremely confusing for everybody, but try to explain that when we talk about these diseases, it's not just like, is it the stomach, is it the small bowel, is it the colon, and what part of the small bowel, but it's also what we try to talk about is what is it involved with the esophagus, what layer of the tissue is involved, because you can get the very superficial layer, it can go transmural, meaning it goes all the way through the muscle layer of the bowel. Or what kind of complications occur? Are we seeing malnutrition? Are we seeing ulcerations? Everybody is different. And I refer to it as kind of the new inflammatory bowel disease because not one shoe fits all. And that's what makes it such a difficult situation for all of us to try to understand with these diseases. What we're trying to do now, based on the fact that CEGIR is developing all these guidelines and we're trying to figure out, well, what are all the differences that we're seeing in these patients, is we're trying to say, okay, well, what are the different presentations and what is the natural history of disease? And so there are recently some publications that have come out, and this one was done by Dr. Dellin and Corey Ketchum at UNC, where they looked at their cohort. And they said, okay, well, if we have multi-organ involvement or small bowel involvement, or if we have more than one site involved, what are we seeing in these patients? Or if we have an adult versus a child. And what they're saying is that flares, that you see more relapsing and progressive disease if you have more than one site involved, meaning you have maybe your stomach and your small bowel. Small bowel seems to be a big key into patients that seem to have relapsing and kind of progressive disease. And continuous disease seems to be more common if you develop this disease as a child, meaning that you don't necessarily get worse and then get better. You just kind of progress and you continue to have kind of this progressive course. Now, this is just off of one registry out of one center. And so more data needs to happen because everything differs. Geographic variation sometimes affects how people develop disease. So we're still trying to tease out these diseases. So you have to, it's hard to have these diseases because medicine is still in the infancy in really understanding the disease. And part of the problem that we have, and part of the reason we have trouble understanding the disease, is that because the disease is rare and because we have a hard time diagnosing these diseases and recognizing them, we don't follow the cohorts very well. So somebody earlier talked about why don't pathologists read eosinophils? Well, that's part of the reason we miss the disease. If we don't recognize to enumerate eosinophils, then we can have missed cases that go on for a long time. And Mirna Shahade actually did a study where she looked at that and she said that there's a delay of about 4 to 9 years of symptoms prior to a diagnosis. So people will have symptoms of the disease for a long time before actually being diagnosed with a lower eosinophilic disease. And why is that? Well, in part, and I'll go over this a little bit, is the symptoms are variable. There's not one specific symptom that you can pinpoint and say, well, that is a symptom of a lower eosinophilic disorder. And then because of that, when we do endoscopy and we try to do our biopsies, sometimes we lack that endoscopy, like the endoscopist doesn't know to do the appropriate biopsies, right? And then when they do the appropriate biopsies, they may not do the appropriate number of biopsies. It's a very patchy disease. And so that maybe we only do 2 biopsies, but we needed to do 4 to really get a good diagnosis. And then when we do the biopsies, if we don't let the pathologist know that we need them to assess for the disease, eosinophils are resident cells in the GI tract. So unless there's something glaringly obvious, we can miss the disease even on the biopsies when the pathologist looks at it. So it becomes this kind of almost like increasing problem that kind of compounds upon itself because the symptoms aren't clear. The endoscopists don't always know when to biopsy. They don't know the appropriate number of biopsies to do, and then they don't know to have that conversation with pathology to look at and to enumerate eosinophils. But what we do know is that these delays can put patients at risk of complications. So this is just one registry study where they kind of looked throughout this large registry of patients throughout, I think it was like Europe and Canada, and they said, okay, well, what are symptoms and how can we really look at the symptoms and correlate that with the site of disease, like in the stomach, the small bowel, or the colon? And really what you're seeing is you're seeing these non-specific symptoms like heartburn, and that can be in people who have multiple sites, eosinophilic gastritis, even eosinophilic enteritis, early satiety, bloating, nausea, and vomiting. And then colitis, maybe you could say that's a little bit better. They have a little bit of abdominal pain, maybe more diarrhea or bloody diarrhea. But again, nothing is really standing out as being one specific constellation of symptoms that will allow you to pinpoint where the disease is and how to do the appropriate workup. So in some ways, you have to throw a wide net and have a high index of suspicion and then start kind of peeling away as you work up patients. One thing Dr. Hirano did do is he tried to looking at an endoscopic score, at least in the stomach, so that we had an idea of whether there are specific findings that we could look at to look for improvement. And he came up with an EGID score. So there is an endoscopic score for the esophagus, and he developed one for the stomach where we looked at, are there multiple erosions or huge ulcerations? Is there something called granularity, kind of a roughness to the tissue, nodules where you can kind of see almost like polypoid lesions, redness, does it bleed easily, and is there like pyloric stenosis, meaning the exit from the stomach is so kind of shut down it's hard to even get an endoscope through there. And he found that these are kind of signs that if there were abnormalities, this is what we saw. And we did feel, what he did look at is he looked at whether endoscopists felt like this would correlate with severity of disease. And the endoscopists did feel that the more endoscopic findings they found, the more severe the disease was. So if we find endoscopic findings, but remember, these are like ulcerations, which are non-specific. A lot of people can have ulcerations if they're taking ibuprofen, if they're taking NSAIDs, if they have other conditions. So again, just remember, all the findings come together and make you think this might be more or less severe disease, but we still have to do the appropriate biopsies. We still have to have a high index of suspicion. And then in addition to that, Robbie Pesek did some studies in the registries and actually said, yeah, that's great. That's great if we find endoscopic abnormalities. That helps us to maybe get an idea of how severe maybe eosinophilic gastritis is. But a lot of patients are actually normal. They come across as appearing normal on the endoscopy. So it's very important for clinicians to be educated to know that even if it looks normal, that biopsies need to be done. And then once you do that, what do we do? How do we diagnose the disease? Well, Dr. Collins gave a great talk about histopathology of eosinophilic disease. And I know Dr. Furuta is going to talk a little bit more about how we're trying to work through ways to make things easier to diagnose the disease. And in part, it's because we've kind of been varied. It's unclear exactly what exactly is the threshold. How can we define a threshold? And people have actually tried to define that by actually saying, okay, well, to really know what's abnormal, we need to know what's normal in the tissue. And so studies have been done where they've said, Dr. Dellon has actually looked at, and Dr. Reed have looked at, prior biopsies that were done in patients who didn't have symptoms that were otherwise potentially normal and tried to get an idea of what is a normal count so that we know what is abnormal. And another study that was done by Turapov and Uchida and Maria Pletneva actually looked at patients. They recruited patients and they said, okay, if you have 0 symptoms, then what are the normal counts? So that way we can get an idea of what is considered to be abnormal. And what they found is that depending on where you are in the GI tract, your eosinophil counts are going to vary. So if you look at these graphs here, on the far left, this is like proximal esophagus, distal esophagus, and then it's gastric body, gastric antrum, 2 different sites in the stomach. And then it's the duodenal bulb, the first part of the small bowel, and then the second part of the small bowel. And then let's go into TI is the terminal ileum, and then you go all the way through the colon. And look at all kind of these counts kind of gradually go up until you hit the ascending colon, and then the eosinophil counts go down. So really, you have to be very particular how you do those biopsies in order to really assess your patients and recognize that the section of the body is going to depend on what is considered to be normal. So this just adds into the difficulty in diagnosing and following disease, and why I think sometimes we are delayed in being able to identify patients. Some of the things that we can identify potentially are, well, what are some other things that would give us a risk? Like, how do we know that patients might have a lower eosinophilic disease? And Elizabeth Jensen looked at that, and some of the risks that she identified is that maybe if you had pregnancy complications, then your offspring is at higher risk of having an eosinophilic disorder, or if they had a NICU admission or antibiotics during infancy, were all potentially some risks that put you at higher risk of having these allergic conditions in your GI tract. And then we looked in Utah because we've been able to look through pedigrees. So we know that if you have eosinophilic disorders of any type, EOE, non-EOE, in your family, you're at higher risk of having a lower EGID in a family member, and that risk extends out to second-degree family members. So it might be really important for clinicians to start learning to take that history or learn that history, so that if a patient's coming in with abdominal pain, nausea, vomiting, and they have a strong family history of an EGID, that we then know that there's a higher risk that that patient also has a lower esophageal disorder. Well, what do we know about therapy? So now we talked about the fact that we're still learning about how to diagnose the disease, and we're not great, and I apologize about that. We're trying to get better. It's a concerted effort by CEGIR and by the PAGs right now to try to make this better for everybody. But what do we know about therapy? You know, we know from some recent data that eosinophilic depleting drugs, despite the fact that this is called an eosinophilic disease, have not really shown benefit in alleviating symptoms in many, many patients with lower EGIDs. Now, that's not all patients, but many patients. And so a lot of these efforts were actually resulted in these drugs being pulled from that effort, trying to get them to the market. So drugs like benralizumab and the drug lirentelimab, which were both eosinophil depleting drugs, failed to show in like follow-up trials that symptoms improved despite getting rid of eosinophils. And it kind of gives us a clue that maybe there's more going on. Like, we call these lower eosinophilic disorders, but getting rid of the eosinophils doesn't necessarily make patients feel a lot better. So there's probably more inflammation going on than just the eosinophil. Well, what Dr. Gonzalez did is she said, okay, well, if they're eosinophilic disorders, knowing that eosinophilic esophagitis responds to diet, I'd like to know if this is food driven. I really want to know if I put a patient on an elemental diet, if I take all those kind of food proteins and remove them from consumption for patients, will they get better? And so she actually did that. She did that through a study supported through CEGIR and through the PAGs, and enrolled like 15 adult patients. And what she found is that when she put patients on an elemental diet for 6 weeks, that she could dramatically reduce the eosinophils in their stomach and their small bowel. But in return, not just that, she got endoscopic improvement with the patients, and the score of abdominal pain and dyspepsia improved as well. So satisfaction improved, pain improved, symptoms improved, along with improvement in not just their transcriptome, so this molecular kind of signaling going on in their body or in their gastric tissues, but also the eosinophils went down. So she did show that this does seem to be very, very, very driven by foods, at least in this pilot study that she did. And then further studies were done through Mark Rothenberg's group and through Cincinnati Children's, where they said, okay, well, we can't get rid of the eosinophils, but do we see a similar, what's called a local type 2 immunity, that allergic disease in gastritis? And they did find that actually in an active eosinophilic gastritis, that we see very similar cytokines that we see in EOE. So IL-4, IL-5, IL-13. And that led to some further thought process that actually, well, maybe this is somewhat similar to EOE and may respond to drugs that have been shown to be effective in EOE. Other studies done by out in Colorado is they looked at IgG4, which has also been shown to be upregulated in EOE, and they showed that that decreases in remission in eosinophilic gastritis. So maybe some of this lower tissue, at least in the stomach, might mimic what's going on in EOE that we know the most about. We know more about EOE than we know than any other eosinophilic disorder. And because of that, then the thought is, well, maybe this drug, dupilumab, that blocks this IL-4 receptor and in return ends up blocking the effects of IL-13, which is very similar to what goes on in EoE. Maybe dupilumab will actually be effective in eosinophilic gastritis. And so they actually did a trial. CEGIR ran a trial with Regeneron Sanofi. It was called the DEGA trial. And this was actually recently just, the final results were actually recently discussed at one of our national meetings. And in this trial, they enrolled 41 patients and they randomized them either to dupilumab, which is FDA approved now for EoE, or to placebo. And then they followed them up at 12 weeks. And what they found is kind of a trend towards improvement. They found that mean gastric eosinophil count was improved, that there was an absolute reduction that was greater in the dupilumab arm over placebo, that the symptoms appeared to be improving, and that the proportion of patients trended towards an improvement. Now, there wasn't 100% improvement in any of this, but things were looking positive, and that molecular signature looked like it was starting to normalize after 12 weeks. So potentially there are some therapies that could be beneficial for eosinophilic disease below the esophagus. All right, I want to go on because I know we've kind of I feel bad that we've talked about gastritis, a little bit about enteritis, and I haven't really even mentioned colitis. The hard thing about eosinophilic colitis is it's exceedingly hard to diagnose and even more rare than gastritis and enteritis, even though it comes with significant morbidity and patients suffer quite a bit when they have it. So Dr. Rothenberg and the Cincinnati group actually looked at this, and they looked at the transcriptome in eosinophilic colitis, thinking at this point, or at least assuming possibly that it would be very similar to what we've already discussed, eosinophilic esophagitis, eosinophilic gastritis. And what was interesting is actually what they found is instead of eotaxin 3, which is one protein that we see highly upregulated in eosinophilic esophagitis, they actually found like eotaxin 1, and that they didn't find the same kind of transcriptome, arguing that colitis may be somewhat of a different kind of entity, even though it seems to run hand in hand with esophagitis. So I think there's more data to be done. It's going to take multiple centers to do this because of the rarity of the disorder. It's much harder for us to study, but it does argue that this is an intriguing kind of finding and something that we do need to explore further in our patient populations. All right, so I talked about how hard it is to diagnose the disease. How hard it is to diagnose the disease, how we're just starting to talk about therapies, that it does seem to be dietary antigen driven in many, many patients, but that it's really, really hard to get a diagnosis or to get people to follow these patients. So maybe what we should do is we should be looking at biomarkers for disease. And that might be a way that we can then find ways to get pathologists to know, hey, this is a patient we want you to look at, or find other ways that we could diagnose patients and maybe identify risk. Is this a patient that's going to move on to have more complications? Is this one that's not? And there is research being done on novel biomarkers right now. Part of that is because we know, and Dr. Collins already addressed this earlier tonight, that pathologists don't routinely address eosinophils in the tissues. And this was a study that was actually done by a pathologist who actually said, okay, if we specifically ask pathologists to rule out eosinophilic disorders, does that happen? And it helps, but it still doesn't happen all that often. So we still have a long way to go to figure this out. But maybe one of the ways we can do this is if we can identify biomarkers, we can let pathologists know this patient is at high risk of an eosinophilic disorder. Could you please readdress looking at that biopsy? And one way to do that is you could look at biomarkers that were done through the CEGIR consortium, where they actually said there are some blood biomarkers that are higher risk in patients that have eosinophilic, at least gastritis right now. And there are some tissue biomarkers. So maybe if we can do a tissue panel, we might be able to then go to the pathologist and say, hey, can you look at this tissue for us? And actually, Ashley Pine, who is a postdoc right now and a PhD and a nutritionist, is actually looking at unique biomarkers just from the aspirates. So when you're getting scoped, you go in, and what we typically do to actually see the tissue is we aspirate out the fluid that's lining the body of the stomach. And so she said, okay, well, I want to look at that and see if there's a difference. Is there something in that fluid that could clue us in that we should be taking a closer look at biopsies? And she did a series of patients, and what she found is she found that, first of all, immunoglobulins are highly upregulated in eosinophilic gastritis, and the aspirates out of the stomach were different than the aspirates from the small bowel, so they weren't substantially contaminated. So she found that that may clue us in that there's something going on in the stomach, and that might be a way that we can then tell pathology that we need to have them look. And then she went further and looked at biomarkers and actually found significant biomarkers in the fluids themselves that you just simply aspirate out and send off for testing. So there are other things that maybe in the future we're going to be much, much better about figuring out for our patients, figuring out for everybody on this call, for all of our family members. And the future directions, I think, are really, really encouraging that there is an effort underway to find new biomarkers, to revise some guidelines that then can guide clinicians and how to manage patients and how to identify a disease so that we're not struggling so hard, so long with symptoms without having a diagnosis. And I know Dr. Furuta is going to talk about some of these newer guidelines that have already been published and the efforts underway, so I'm not going to go into detail. But what I did want to say is just in summary, thank you for listening. Just remember that if you do have eosinophilic disorders in your family, you're at higher risk for having eosinophilic disorders in other family members. And having one eosinophilic disorder increases your risk for having others. And remember that the symptoms can commonly overlap symptoms of things like irritable bowel, dyspepsia, heartburn, so that they can sometimes be misdiagnosed because of this non-specific symptomatology that occurs. And that we do need to have a good conversation with our pathologists to have our concerns expressed so that they can help us identify disease, and that the phenotypes will differ. We are seeing some efficacy. We now know that there's some benefit to dietary trials potentially in these patients, that dupilumab is showing some trend towards efficacy, and newer novel therapies are being currently investigated. So in the next year or two, when I talk, hopefully again, I'll have some more information that's very encouraging for everyone. And with that, I just wanted to thank you all for listening.
Thank you so much, Dr. Peterson. That was great, so informative. And if you can stick around to the end, we will do questions after. And at this point, I would like to introduce Dr. Glenn Furuta. He's the section head of pediatric gastroenterology and hepatology and the director of gastrointestinal eosinophilic disease program at Colorado Children's. And Dr. Furuta is also a principal investigator with CEGIR, and just another very passionate and caring doctor that we're so lucky to have in our community. So thank you for being here.
Thank you, Ellen, and thank you, Shay, for this opportunity to be here today. My disclosures are shown here, and Shay and Ellen had reconstructed the schedule just in case that I was not able to get out of clinic in time. So this presentation really, I think, will help to put the framework around all the excellent presentations that you've heard today, and speaking about the diagnostic guidelines for eosinophilic GI diseases. We'll cover 4 different topics today. We'll talk about the anatomy of the gastrointestinal tract that you've heard about in many ways already, the development of diagnostic guidelines. Why is it so important to have those? What are the present guidelines, and what some of the next steps might be? So I did want to start by thinking about the gastrointestinal tract. A picture is shown here on the left-hand side of this slide with the stomach and the small intestine and the colon. We've talked a lot about the esophagus, but we're really talking about these lower organs. And the GI tract is really a series of 4 different organs, including the esophagus. You can see the surface that is appeared endoscopically, and the tissue that was described by Dr. Collins that looks normal here. This is the stomach, a normal appearance, and this is the hole that leads from the stomach out into the small intestine called the pylorus, and the normal stomach tissue here. The small intestine that's composed of 3 different parts. You can see the circular folds and these finger-like projections that help us to absorb the nutrients. And then finally, the colon that Dr. Peterson spoke about, shown here, that is smooth and has these absorptive cells because the function of the colon is to absorb water, so we have a formed stool. Each one of the organs has different structures. Each one of them has different functions, and all of them actually contain eosinophils, which provide some of the confounding issues that have been discussed. And eosinophils normally reside in the gastrointestinal tract. Dr. Peterson had spoke to you about one of the studies that was done in her institution. It's been shown in others that there are normal numbers. This is each one of the sites along the intestinal tract with the numbers shown in the black bars. And you can see, very similar to what she showed previously, that they go up and they come down as you go down from the top to the bottom of the intestinal tract. Also important to think about is what Dr. Collins had said, that the tissue itself is shown here. This is a picture of the esophagus. This is a picture of the very top part of the esophagus. And the only thing that we really have the opportunity to look at under the microscope is this very small piece. And that's what the pathologist has to count the eosinophils and or do all the other assessments that need to take place. So very small piece of tissue that which much is gathered from. Well, what are the functions of the eosinophils if they're normally there? And I think in many ways we've helped to identify the potential beneficial aspects of eosinophils present, which include antimicrobial, in which they can kill viruses, bacteria, parasites. Perhaps they're anti-inflammatory, and more commonly, we think of eosinophils as being harmful as they increase in other states, including allergies, tumors, and other intestinal diseases, as has been described in a review by Joanne Masterson shown here. This is just a diagram to show the normal intestinal tract with the lumen here where the food courses through. There are normal bacteria that can be present there, the surface cells that we've talked about in many ways. And then you can see that the eosinophils are directly opposed to many of the resident cells that are normally present in the gut, including cells that secrete mucus, nerve cells, and muscle cells. So it makes for somewhat of a confounding factor of what are normal numbers and what are abnormal numbers. And so the first point I wanted to leave you with is that the GI tract is a series of 4 hollow organs and 2 solid ones, meaning the pancreas and the liver, and all of them have different structures and functions, and that the eosinophils are normally present in the GI tract except for the esophagus. So let's think about now, what does it mean to develop diagnostic guidelines, and why do we need to do that? And I think the bottom line is that we want to develop some uniformity and consistency for clinicians who are caring for patients and making the diagnosis, and researchers who are performing studies to understand these diseases and help develop new treatments. So we want to diagnose patients properly. We want to make sure that everyone is reading from the same book to make sure the diagnosis is consistent. We want to have guidance for research studies, meaning that if a patient is enrolled in a research study, that there is some rigor to thinking about who those patients are and make sure that they're all quite similar. These help us develop new treatments. We can also track the epidemiology or natural history of a disease if we know exactly who those patients are, and it also helps to support billing practices. But diagnostic criteria are very important in each of these regards. Well, how do they develop? And this is just a model for guideline development in which we want to think about what are the symptoms that may be associated with a condition. You've heard much of that already from Dr. Peterson. We want to think about what tests may be supportive or help to understand what that disease is, and in diseases that can include blood, x-rays, as we've talked about for EGIDs, endoscopic features, and perhaps genetic models, as Dr. Peterson had described also. For eosinophilic GI diseases, we've relied on the number of eosinophils that are present in the tissue. And then also we want to consider about what else may cloud the picture to make that diagnosis. This was described in previous presentations today, that there are other things that can cause eosinophils to go there. So we want to make sure that we can rule that out. So a number of different things that are considered as guidelines are developed, and who does that and how. And you've heard in many of the presentations already about CEGIR, which is the Consortium for Eosinophilic gastrointestinal disease researchers. It is an NIH funded, a federally funded group of investigators that team with our patient advocates, including CURED, to think about how we can improve the lives of patients. And these are pictures of both in-person meetings, shown here on the right, Zoom meetings, as shown in the upper panel, and in-person meetings that happened recently at our DDW meeting, where you can see many of the speakers who have participated today, including Drs. Gupta, Collins, and Peterson, who think about what these features are with respect to guideline development. And so there are a number of
Dr.
people.
Furuta,
Yes.
we're seeing somebody's chat on the screen. I just want to make sure, is it yours? Okay.
No, is it moving now?
Well, it stopped moving. Now it says that you're sharing your screen and we don't see it. Somebody was instant messaging and I just wanted to make sure everybody else couldn't read it. So
Oh,
sorry to
okay.
interrupt. It looks good now.
Okay. There is this, it says talking from Glenn Furuta right now.
Yes, it does.
Okay. That's just from the chat. I don't know how to get rid of it.
Oh, okay. It's good now. I can't see it.
Okay. So the second point is it takes a lot of time and thought to develop these diagnostic criteria. They're going to be useful both for clinicians as well as for researchers. Well, let's talk about the guidelines, the newest guidelines that have been developed for eosinophilic GI diseases. And we'll take a few minutes to think about how this has happened. And you've seen some of this before, and I wanted to just call your attention to this. Dr. Peterson had brought it up before. This is actually the number of people that were involved in developing a way to make sure the terminology was right. And you might be saying, wow, that's a lot of people to think about what we're going to call something, but it's so important to make sure the terminology is important before we go on to develop diagnostic criteria. And so in this box, you can see that this group of people got together over a series of about 3 months to make sure that these different terms, eosinophilic gastritis, eosinophilic enteritis, and eosinophilic colitis, all were able to be had the right terminology so people knew what this disease might look like and going forward. So took a long time to talk about, but we need to agree on what to call a disease before we can go forward in making the diagnostic criteria. And then subsequent to this, a combined effort between the European Society of Pediatric GI Nutrition and the North American Society of Pediatric GI Nutrition got together over a series of years, actually, with the folks shown here, again, large numbers of people, inclusive of pediatricians, as well as adult providers, allergists, gastroenterologists, and pathologists across the world to think about what each one of these diseases might be used to diagnose them. In the stomach, as we saw, in the middle of the duodenum, and the colon. And this was the algorithm that was developed around that. And we'll walk through this to say that this is a pattern, an algorithm to think about that was developed by 26 experts from 5 continents. There were 34 statements and 41 recommendations. And we'll just walk through this briefly to say, how does one make the diagnosis? And you think back to those guidelines previously, you need to have symptoms that are present. And those symptoms are suggestive of the disease, whether that's just lying on the surface, whether it's inclusive of the muscle, or whether it's going through the whole thickness of the intestine. What are those symptoms? And again, the 26 experts who got together thought about this and put together a symptom complex. Next, what does the endoscopy look like? Is it normal or abnormal? And what are the features that are associated with that might lead us to make the diagnosis? And then the tissue eosinophilia. What are the numbers that are normal or abnormal? And this took a number of calls and discussions to say, what are the numbers that would be abnormal in the stomach, in the small intestine, and within the colon? And here are the numbers that were identified that would be diagnostic for patients overall, that would allow us to consider the diagnosis of a non-esophageal eosinophilic GI disease. So the third point is that diagnostic criteria contain different types of measurements that typically include the symptoms and other features, and in particular for eosinophilic GI diseases, the endoscopy and the histologic or tissue findings that are present. Well, finally, let's just think about what are the next steps that we might want to think about as diagnostic guidelines are developed. And we've discussed this briefly, but it's important to think about that the eosinophilic esophagitis diagnostic guidelines have been revised 3 and actually 4 times now over the course of the last 18 to 20 years. And so it's important to think about as we learn more and as we accrue more experience in understanding and caring for patients, we want to make sure that we can revise this to keep things current. And in line with what Dr. Peterson described earlier, we have a way to assess what the esophagus looks like in eosinophilic esophagitis, and now we have a way to think about what does the stomach look like in eosinophilic gastritis, and the sense of ulcers that are present, the nodules that have been described, this thickening of the folds, and this actually very reddened appearance that suggests irritability. So we have a way to measure this, and we can track the disease and also use this to help develop diagnostic criteria. We also will learn, and things that will happen over time, is what happens to patients who have these diseases. And it's a really important part of thinking about what's called the natural history of a disease. This was work done by Laura Quinn in our group, in which she looked at 128 children who had the diagnosis of eosinophilic gastritis or duodenitis based on criteria that had been established previously. She saw what happened with them in follow-up over the course of about 6 years. And what she found was that over time that there were actually only about 25% of those patients ended up having chronicity to their symptoms, meaning that the symptoms persisted, the inflammation persisted, and that the rest of the patients actually either seemed to outgrow this or had diagnoses of other diseases. So this is an important part of what happens over time as we learn more about the disease, allowing us to mature our diagnostic criteria as things go on. And that leads us to this, which we won't go into in a high degree, but it's an upcoming diagnostic criterion, which we'll think about, again, the symptoms in what we've learned over time, what the proper numbers of eosinophils are within the tissue that may lead to disease. Is it present for a longer period of time than just one time? And then are there other features that may be suggestive of this disease? So new diagnostic criteria are based on accumulated knowledge and research that has accumulated. So the fourth point is that based on new observations and research, diagnostic criteria will continue to evolve and improve to benefit patient care. So if you hear, wow, they changed something again, or geez, what are they doing? Why are they always updating and doing things that seem to change what was happening before? It's because we've learned more, and we want to make sure we're doing things in the best way possible for our patients based on the evidence that there is to date. So I'll end there, and I know we have a number of different questions that have been developed, but I appreciate your time late in the evening here. Thank you very much.
Thank you so much. Our first question is, at what age should we start testing siblings of EGID patients, especially if they have a history of allergies and milk protein allergies as babies?
Well, I think for any patient, I don't know if that you want to direct that to anyone in particular, but I think the diagnoses of patients rely on symptoms, and then there's that critical point of saying, when do we do an endoscopy for a patient? And for me, it really does relate back to growth and development. We want to say, is a patient growing and developing properly? Are they achieving milestones that they need to? Do they have any complicating features related to laboratory abnormalities that could include anemia or low protein in the bloodstream, or things that are such extreme in nature related to complications that would necessitate going forward with an endoscopy to make a diagnosis.
Thank you. I don't see any other questions. I know Dr. Gupta answered all of his questions via chat. Does anyone have any questions that they would like to ask for either Dr. Peterson or Dr. Furuta? Feel free to put them in the chat or even raise your hand and take yourself off mute and ask. Stephanie, it looks, oh, Stephanie said, it seems like that, Dr. Furuta. If no one has anything or any questions, thank you all so much for being here and taking your time and spending the evening with the CURED family. And thank you so much to our presenters. And if anyone has any questions after this that they think, feel free to email Shay or I. Our emails are in the chat and we can direct the questions to the right physician for you and get your answers back. And everybody have a really good evening and we will see you tomorrow.
Thank you.